Thank you. Let's go to this audience's questions. I think we've got a man with a microphone in the middle. If you raise your hand and give a wave, I see this woman over here, this lady right over there. I think we need to wait for the microphone so that you can be captured on film forever. Your words will be held against you at some point.
Okay, great. Hi, I'm Nancy Chalkley, and my question is for Lenny Mendoza on the end. First of all, I'd like to tell you this is a terrific report. It's really excellent and communicates a lot of information very clearly. One of the obvious things that communicates the need to do something about outpatient care and the cost associated with that. So we've thrown around the term czar or your advisor to Barack Obama. What do we do?
So, first of all, thank you for the compliment, and you're a lovely human being as well. What I would say is that there is no silver bullet to this. When you've got a systems problem, there is no one pill you can take to solve the problem. As I was describing earlier, the incentives are misaligned throughout the system. You need to deal with both the payment system reform that we were talking about earlier to create the right incentives to ensure that there is fundamentally much larger group of delivery systems that are doing what our colleagues on the table are doing, which is imagine what could happen if you incented the delivery system to have as an efficient a production system as Toyota does, or as an efficient and cost-reducing supply chain that Walmart has, or as delivery of value to consumers and innovation that Apple does. I mean, we need to realign the incentives so that the Americans' private delivery system has those sorts of incentives as opposed to more outpatient care.
I think the gentleman here has got a microphone.
Yeah.
Tell
hi.
us who you are and who you're with.
Yep. My name is Bill Settlemar, Charleston, South Carolina. I'm with SC Business LLC, actually a company I founded. I no longer own, but they haven't thrown me out yet. But I wanted to speak from the standpoint of the small business entrepreneur. I founded my company 13 years ago, built it up as soon as I could, tried to make sure that my employees had group health care because I thought it was very important. The answer to what do you do when you start out, you have to be married to a nurse who works for a great healthcare system and has access to health care. And otherwise, you got a real problem, except for the young people who don't know that they need coverage. It's a very serious problem, but it goes beyond that. It also puts small business at a disadvantage against big business. And it prevents the movement of employees from employer to employer based on the attractiveness of all the other things that employers can offer. So this system goes up and down and back and forth in terms of keeping people where they are or keeping businesses from growing. And I was just disappointed to hear my own business, which I no longer own, has had to cut benefits further, health benefits, in order to deal with the current downturn. The second thing, just on the reticence of business, I'm not here because I'm not reticent, but we in our own community have pulled together a discussion group of providers and hospitals and employers and nonprofit groups. We held a discussion for the Obama transition team and sent in a report, and just a comment that I think that the way that something's going to get accomplished is these kind of up and down communications between here and Washington are going to have to be nationwide. And those of us in the hinterland, we are totally befuddled by Washington and wonder what is possible to accomplish. But there's got to be a way to get it done, and that's how it looks from my end of the world. So.
That's great. I think we should take that as a comment, just in the interest of getting more questions in. Do we have, I see this lady over here. If we have a microphone that's being rushed over to her, she'll stand and tell us who you are.
I'm Barbara Dyer with the Hitachi Foundation, and I'll try to make this a question. There are 12 million or so people employed in the healthcare system, and about 6 million of them are frontline workers, people below doctors and nurses, people who are spending more time with patients, but for whom we don't really have a very good approach to cultivating their skills and talents. And with that part of it, one, I wonder in the McKinsey analysis whether there's been a disaggregation of labor costs in a way in which returns like Virginia Mason's approach to training their frontline workers are being realized in the cost savings. So how to think about frontline workers in this mix, the labor aspect of this, is rarely mentioned. It's also an area in the U.S. economy where job growth is occurring as everything else is declining. But a systematic approach to cultivating talent among frontline workers seems to be missing across the board, and that's an area that needs quite a bit of attention.
Let's take that as a question. And Lenny, do you want, or Dr. Gaba?
I think that's a tremendous power in our system. And one of the great things about putting Toyota Production Systems into healthcare is that you really do capture the talent of your workforce. So we've trained 160 people as black belts in Toyota production, and we've run 200 rapid improvement events, and those are multidisciplinary. Frontline clerk in the same room with a neurosurgeon, which the clerk's probably better than the neurosurgeon in that environment, but to see the first time I saw a clerk who never had used the word data stand up in front of all the executive staff and do a report out and talk about tack time and pull and how they had fixed the problem that they were working on that week is not only inspiring, but it inspires the workforce and it harnesses the tremendous talent that we have in the healthcare workforce. But I think we need to look at tools like that are different from our standard model if we're going to achieve what you're asking about. But it is achievable.
Other questions? I see a gentleman somebody over there who's got the mic already. Tell us who you are, sir.
My name is Russell Mokhiber. I edit a legal publication called Corporate Crime Reporter. This is a little bit off that topic. And I came in late, so if you've addressed this, I apologize. But there is a national movement for single-payer health care in the United States. About 90 members of the House have signed on to a single-payer bill, H.R. 676. The majority of doctors in some polls support it, a lot of nurses, a lot of the American people. And I'm wondering generally why in conversations like this, single-payer is off the table.
Who would like to take a crack at that? Many takers. Dr. Walter.
Well, just a personal point of view, I'm personally somewhat agnostic to the issue of single-payer versus the continued public-private funding, because whether or not we go to single-payer, we still have to deal with these underlying structural and delivery problems that we have. I would say this, there are some who believe that as we move toward universal access, single-payer should be an option for individuals under age 65 or for businesses, and I think that is an intriguing thought because it might be that competition can improve both private sector and Medicare, and so maybe that would be one way to think about how to include single payer as we move into new ways of funding universal access.
I think we've got time for one more question. By the way, if you're interested in the question that Dr. Walter was just talking about, Jacob Hacker, who's one of the leading proponents and analysts of this thing, has a great paper out making the case for the public plan option as part of the stuff that's serving folks who are under 65 who don't have access to group coverage. And I think it's at the Institute for, if you just Google Jacob Hacker and public choice plan, you'll find about a great 20-page paper on it. I think the last